Hello, everybody. I'm Dr. Suvadeep over here, and we'll discuss the. I've taken an exam on EDIC Part 2 exam, mock exam, with one CCS and one CBS, few CBS scenarios. I do not know. I just trying to find out who was there in my class in that. Is there anybody who has given exam, this mock exam with me?
Yes, sir.
Right. Yes, Dr. Anu was there.
Yes.
Right. Dr. Anu was there. Anyway. So I don't want to give any marks and all. So whatever questions that we have asked or discussed in that mock exam, we'll try to understand how to answer in your exam, and you assess yourself. Probably that is the best thing over here. I don't want to give any marks to verify. One person did very well. I just remember, but there are, I think, few of you had some problem in what you were telling, how well you were telling, and then in addition to what happens at the most of the time, the and all these European examinations, the examiners are also provided with the standard answers for each and every question. So they just try and look for the whether your whatever answer you are giving, that is almost telling, or the key points are there, key messages are almost tallying with your answer or not, and that is how they give, and they give you marks. So if you miss one particular thing, then they cut your number. So even though sometimes you do not tell, or sometimes you miss that one point, your marks will be reducted because you have not told. So that is how it happens. So try to be as precise and as to the point in EDIC Part 2 exam as much possible, and that helps because nobody is interested to listen to a lot of stories in the exam. Anyway, the CCS that we have discussed is about a 34-year-old gentleman came with a pain abdomen radiating to the back with some low-grade fever. We have given some basic lab sets that is done at the time of admission. I hope everybody has gone through the clinical case that this case being vignette. So the questions that we have started, how we have started is that how is your diagnosis? Is a very standard questions, and what will be your differential diagnosis? All of you has were able to do the diagnosis part, but diagnosis is it is just
Acute edematous pancreatitis.
Yes.
yes, acute edematous pancreatitis. So like again, this is one things that I would like to mention. Few of you have told me what is the diagnosis. Somebody have told that it's pancreatitis. So please complete your sentence over here because that is very, very important. Because if you see, you have been provided with some amount of CT scan image as well. So in your answers, this acute term has to be there. Uh, so it has to be your answers will be acute pancreatitis. You can say edematous because this is more. There is no evidence of necrosis that you can see in the CT scan. If you tell the person they were edematous pancreatitis, that is better. But it is first day CT scan, so there is some patches there. So maybe necrosis might come or not. You may or may not say about that part. So, but your answer has to be acute pancreatitis. Differential diagnosis, most of you as a kind of are aware of. It's anything is acute abdomen. So in this also examiners will be having a set of DDs like 5-6 DDs they will be having in their placard, or in most of the time they sit with one laptop or one tablet or something like that, and they keep on tallying whether your answers is tallying with the answers that has been provided to them or not. So try to match, try to give as much details as possible. Yeah. But the question starts from this point. So once you know that come to a diagnosis of pancreatitis, the question will start on the pancreatitis. How do you diagnose pancreatitis? What lab test we will use to diagnose the pancreatitis? What etiological workup? So again, in the exam, I have intentionally separated the questions to give you lead. But whenever you talk about somebody asks you about the diagnosis of pancreatitis, your answer should be first of all how to diagnose what are the tests with which you will diagnose pancreatitis, be it clinical and be it laboratory, be it radiological. You need to give entire things. And what lab test, regarding the lab test part, first of all, the lab test would be directed for the diagnosis part of the pancreatitis, for assessment of the severity of pancreatitis, and thirdly for assessment of the etiological work. So all these things, three things has to be there. I have divided the questions so that to give you a lead, but in the exams you will not be given that kind of lead. So, but it needs to encompass the all three things. What test for the diagnosis part, what test for etiological workup part, and what test for understanding the severity part. So those, all everything needs to be there, and you can categorize your answers as per that. I'll come back to that thing. I'll just see the questions whatever I've asked. Again, in the diagnosis part, most of the time, I remember. I think only one person told about the amylase and lipase. Rest of that, all the rest, probably they have not talked about amylase lipase also. So, so I had to lead them. So in the exams, nobody will be there to lead, because your next questions will be based on how well you have given answers to the your first question. So very basic thing, managed lipase, most of the time probably you must have thought that the okay, amylase lipase is too common. You have presumed, you have already got all this lab test, but whenever you have been asked the kind of definite questions, you need to provide a complete answer. So it was very, I thought probably you must have presumed that amylase lipase will be there, so that is why you must not, you probably have not told. But to my surprising, only one person talked about amylase lipase in the answers part regarding the diagnosis of pancreatitis. But otherwise, it was okay. How to classify disease severity? Again, very important questions in the exams. You'll be asked regarding the classification of the disease severity. I'll come back to how to answer that part. What are the complications of acute pancreatitis? Again, I will come back. How will you manage these patients? Again, I have given a lead in terms of how you do fluid management, analgesia, antibiotic, nutrition, disease management. So, but in the exams, you will not be given this kind of leads. So, whenever you answer regarding the management part, you need to talk about fluid, you need to talk about analgesia, you need to talk about antibiotics, you need to talk about nutrition part. So, all these things has to be there in your answer. So that is why we have, do not expect this kind of leads in your EDIC Part 2 exams, but try and categorize, or try and specify your answers as much as possible, because that tells the examiners how organized you are in the thought process in the exam. So we'll discuss certain things about the pancreatitis in the next part. Diagnosis, again, any two of the following: somebody coming with a pain abdomen, with a lipase more than 3 times the upper limit of the normal, and or with abdominal imaging or finding of the pancreatitis. Most of the time we do with a EVC. Uh, so any two of them is positive, that favors the diagnosis of pancreatitis. So that goes in the diagnosis part. Examiner might ask you regarding the amylase lipase a little bit. How sensitive specific? So we all know the lipase is a little bit more sensitive than amylase. Amylase might be normal in a lot of patients. Amylase lipase may be elevated in a lot of other patients with a pain abdomen as well. So you need to be aware. What are the other abdominal condition where amylase lipase are falsely elevated, except pancreatitis? And so that is about the diagnosis part. So regarding the CT scan, again, CT usually prefer to do towards the late part. We usually do not do a CT scan in the early part of the pancreatitis unless your diagnosis is in doubt. Uh, in case the diagnosis is otherwise confirmed, we prefer to do a CT scan after 3 to 5 days of the onset of symptoms. We usually do not jump to do a CT scan immediately. And CT scan is usually diagnosis. It's a good sensitive test to identify that somebody is having pancreatitis or not, but not to consider doing a CT scan. Try not to talk about the. We'll do a CT scan for the diagnosis of pancreatitis. Try to avoid CT scan for the diagnosis of pancreatitis as much as possible in the exam. In the exam, we should say that we'll try to delay CT scan after 3 to 5 days. Uh, uh, Usually try do not do CT scan on the period. Regarding the scoring system, regarding the assessment of the disease severity, we use a lot of scoring system. So scoring system can be specific for the pancreas, can be in general scoring system like Ranson and Glasgow and the BCFs are more specific of the pancreas specific scoring system. The Apache 2 and the SAP score are more kind of physiological scoring system, which is not specific to the pancreatitis, but they correlate well to understand the severity of the pancreatitis a lot. There are a lot of times that they perform better, even the Ranson and the Glasgow. We should know what are the drawbacks of Ranson and Glasgow, what are the drawbacks of the Apache 2 and SAPs. BCF, everybody should know about the BCF score. I think two or three of you talked about the BCF score to understand the disease severity. You should know the component of the BCF score. I'm not going into details of these things because I just want to give you the kind of glimpse what we should talk in the exam. But what is most important, how do I identify the severity of the pancreatitis? It is Atlanta classification. You should all know about the modified Atlanta classification of severity assessment of the pancreatitis. It's divided in the mild pancreatitis, moderately severe pancreatitis, and severe acute pancreatitis. Mild, I hope everybody know, mild means no organ failure, no local or systemic complications. Moderately severe means where patient comes with some organ failure, but that resolves within 48 hours of period of time. And severe means when there is a persistent organ failure beyond 48 hours. That is a severe acute pancreatitis. How do I understand the organ failure is there or not? We use a modified Marshall score to identify the organ failure, to identify the absence or presence of the organ failure. So Atlanta, everybody should talk about this Atlanta classification. If the examiner asks how to do a severity assessment in the patients with the pancreatitis, always please talk about the Atlanta classifications of severity assessment. Prefer not to talk about this Ranson score, Glasgow score because they are outdated. Most of the time we do not use in the bedside most of the time. Talk about the bicep score, which is important, and examiner would like you to know about the bicep score. But Atlanta classification is a must for everybody to know, and everybody for you to give answer in the exam. CT scoring system again. If you're giving a good examinations, then people will ask about a CT scoring system. Balthazar scoring system we use to assessment of the severity of the pancreatitis on the basis of CT scan. It's a contrast enhanced CT scan to identify the necrosis part and to identify the inflammations part, whatever is there. Coming to the management, again, in the questions, I have divided the management part in terms of fluid, nutrition, antibiotics, and everything. But the exams, again, you need to give answers in a very congruent way or any organized way. Like patients come with the pancreatitis, we'll assess and then we'll start our fluid management. Most of the patients with the pancreatitis requires fluid because they are in a severe inflammation, and they have a lot of third spacing. So patients we usually give crystal as a fluid. Usually, in all patients, we prefer to use lactate and ringal solution as the preferred solutions. And then the meta-analysis that happened in the patients with the pancreatitis, and it has been shown the use of RL or lactate and ringal lactate has some some benefit in the clinical trials as well over the normal saline in patients with acute pancreatitis. So if somebody asks the which fluid, everybody should say that we use ringer lactate solution as a balanced crystalloid in patients with acute pancreatitis. We do not give fluid more than 24 to 48 hours. If we give fluid more than somebody is requiring fluid more than 24 to 48 hours, that means something either we are missing something or something else is happening that we need to try and find and identify. And somebody who is persistently requiring fluid beyond 48 hours, that is a poor prognostic marker because that means the inflammation is still there even after 48 hours. So that is a marker of severity of the pancreatitis as well. So, like anybody who is a positive fluid balance more than 6 liter at the 48 hours is a poor prognostic marker of the outcome. So it's not that we do not need to give fluid, but we try to cut down the fluid as much as possible after 24 to 48 hours. Analgesia and antibiotics, very important part of the management of the pancreatitis. Most of the time we forget, but again, both in our clinical practice and in the exam purpose, we should talk about the analgesia part. Uh, Usually, always tell in the exam that we use multimodal analgesia to for the pain management in patients with pancreatitis. We can give acetaminophen or paracetamol, and we can give opioids as a systemic analgesics. If the pain is persistent despite giving systemic analgesics, we should give epidural analgesia along with some local anesthetics and some opioids. But most of the time, we do not give provide epidural analgesia to everybody because most of the time they are hypotensive. They keep on requiring a lot of fluid. So sometimes we tend to avoid epidural analgesia to most of the patients unless the pain is getting sorted with the systemic analgesics. We usually prefer to avoid. But try and use the words like multimodal analgesia, patient control analgesia, all these terms more and more in the exams, and try to use. We give paracetamol, we give systemic opioids. We prefer to use short-acting opioids in these kinds of patients, and pain management is one of the very important aspect in the intermanagement of the pancreatitis uh, because unless you address the pain part, the patient persistently remains in distress, and other patients will remain tachycardic. You might not be able to understand whether this tachycardia is because of this pain or because of this hypervolemia state or not. So you have to take care of the pain. So that is very important. Antimicrobials, we do not use prophylactic antimicrobials in patients with pancreatitis. So whenever I talk about the antibiotics, so always say that no routine prophylactic antimicrobials we give in patients with acute pancreatitis unless we suspect strongly there is some strong source of infection. Is that okay? Anything is there? Proceed. Next question comes: when we suspect infection in the pancreatitis, usually the infection peaks at the end of third week, but infection may happen most of the time. The cause of infection is the bacterial translocation because we keep the patient's nil per oral, and the abdomen remains. If the abdomen or gut remains in the ileus, there is a lot of bacterial translocation that happens, and that is a cause of infections over here. But and anybody who has a bile duct gallstone pancreatitis, they might be having associated cholangitis, or if the pancreatitis are associated with some perforations or something like that, then we should try and find out and we need to treat the infections. Indication of surgery, somebody will ask, may ask that when you at what are the conditions where you should do a surgical intervention in pancreatitis. For most of the pancreatitis, surgical intervention is still no because even though the necrosis is too much, more than 50%, 60%, 80%, so we do not sort to doing a surgery nowadays. Previously, necrosectomy was one of the early surgeries that people used to consider, but again, you need to understand that pancreatitis is a systemic inflammation. It leads to systemic inflammation. In any early surgical step, just adds up to the systemic inflammation and then makes the intermanagement difficult. So usually in pancreatitis, the surgical things are better avoided unless somebody has some perforations or respiratory hemorrhage, or somebody has a hollow viscous perforation, or somebody is developing abdominal compartment syndrome kind of thing, then you should think about a surgery. But otherwise, most of the time, we do not do a surgery. And even if we do a surgery, we try to sort the minimally invasive surgeries as much as possible. And we try to do any kind of surgical interventions which is least invasive. So that is the most important thing. Feeding, again, very favorite questions being asked to the candidates in the patient with pancreatitis. So again, there is no concept of bowel rest in pancreatitis. As soon as the pain is under a little bit control with your systemic analgesics, we should start feeding. Usually, feeding, somebody is able to take oral feeding. Oral feeding is okay. There is no. It's not that all patients needs to have an NG and then start on the enteral nutrition. It's not. It's not. It's not required. If somebody is otherwise conscious, most of the patients with the mild acute pancreatitis or moderate severe acute pancreatitis, uh, oral feeding, we can start oral feeding as early as possible. Who is sick, severe acute pancreatitis, in those patients, most of the time they'll end up in the enteral nutrition in form of NG or NG feeding. Again, there is no benefit of NG versus NJ. NG is rather easier and quicker in somebody where there is any uh, somebody who has a gastric atony, or somebody who has a kind of any somebody in the gastric atony, or where there is gastric ileus is there. In that case, patients we can sort to nasovaginal feed, but otherwise there is no benefit of nasogastric over nasovaginal feed. Sometimes patients, suppose somebody has developed hollow viscous perforation or something like that. In that case, patient might need to stay, or somebody who is in a persistent ileus, patient might need to remain in. You will not be able to start enteral nutrition in those patients probably. In that case, you may use TPN, but again we try to use TPN plus enteral nutrition or combined nutrient support as much as possible. And MCT based diets sometimes are better in terms of assimilation and then absorption. So we'll progress. So that is how the first part of the question ends. Then we're continuing the case vignette over here. So now the patient is in day 3 of the patient is in the ICU. Now the patient remains sick. Patient is tachycardic. BP is okay. Pain abdomen is persistent despite on fentanyl infusion. Patient's respiratory rate is high, saturation is borderline, abdomen is distended, uh, and he is in a positive balance. They've been given some amount of uh, labs over here. What do you suspect? Anybody? What do you suspect over here? Everybody is listening?
Acute compartmental syndrome, acute abdominal compartment syndrome.
Yes, very good. So again, the first stage is that identification of this condition. But again, unfortunately, in that most of the candidates over there in this mock exams, they could not identify the abdominal compartment syndrome part. So unless you identify the abdominal compartment syndrome, what the next questions will not come. So try and identify the condition first. That is important. And then the next question starts the how to measure abdominal pressure, what is intra-abdominal hypertension, how do we differentiate from the abdominal compartment syndrome, and all, and what will be a strategy of management. So abdominal compartment syndrome means anytime intra-abdominal pressure more than 20 along with a new and worsening organ failure. So that is the definition of abdominal compartment syndrome, which is given by the World Society of Abdominal Compartment Syndrome. The grading should know what is intra-abdominal hypertension. Intra-abdominal pressure more than 12 is intra-abdominal hypertension. So both the entities are different. Intra-abdominal hypertension along with organ failure that is associated with that means that it is abdominal compartment syndrome. Any patients with a severe acute pancreatitis always suspect abdominal compartment syndrome, which is important. Management part, talk about the first of all identification of the condition, medical management, what we do for the intraabdominal reduction of the intraabdominal pressure, and the surgical management. So you should categorize your answers as per this. There is a standard guidelines are there. Again, I'm not going into details of this part. I think everybody must have read, but you just give your answers step by step. What will you do? Suppose you are suspecting intraabdominal hypertension. You will first of all try and measure the intraabdominal hypertension, intraabdominal pressure. You identify the intraabdominal pressures, and depending on the intraabdominal pressure, the degree of the intraabdominal hypertension, you classify your management, or you start the treatment of it. How do we monitor the intraabdominal pressure? Most of the time we measure intraabdominal pressure by putting a catheter inside a bladder, and we measure at the end expirations. So everybody should know that how to measure the intraabdominal pressures. Both it is important both clinically and both from the exam point of view. Where do we keep the transducer? How do we do a zeroing? What is the normal intraabdominal pressure? Which positions do we measure? What time of the breathing cycle we measure? So that is how we do. Uh, Again, somebody who is spontaneous breathing, it is a little difficult to understand, monitor intraabdominal pressure, because as per all pressures, they are best measured when somebody is a positive pressure ventilation and sedated and paralyzed. But it is important to identify the intraabdominal hypertension, and please remember what are the steps of measurement of the intraabdominal pressure. This is a kind of bladder catheter that we use. So we'll proceed. So any questions so far in terms of the pancreatitis and the management and anything? Because now the questions will turn in a different direction.
Doctor, regarding to feeding, the
Regarding,
nutritional feeding,
yes, regarding the feed.
regarding to any specific time, 24 hours to 48 hours, or just early as soon as possible?
No, so as soon as your pain is a little bit under control, you feel that the systemic influence is under control, so you just start feeding at that point of time, at that time only. Preferably, it is better to start within 24 hours of time. I'm not telling you to start as soon as the patient comes to the ICU, tell the patients to eat. That is not the dictum anywhere. But at the same point of time, patient comes and try and assist, start the resuscitation part, and as soon as the patient's pain under control and the vomiting, nausea part is under control, we start some form of oral nutrition things. That can be even
Okay,
glucose water, that can be even saline, that can be even some soup, anything. It is important to send things inside your stomach. So that is important.
So in brief, in medical management for
Hmm?
so in brief for medical management for abdominal compartment syndrome
Yes.
in exam, what quickly we can say about this? Just NGT decompression and rectal tube or rectal flatus tube like this.
Mhm. So most of the time, it depends on what is the reason for abdominal compartment syndrome. Like here in the acute pancreatitis patients, most of the time the abdomen becomes distended and patient goes in abdominal compartment syndrome because of the third spacing part. So that is why after beyond 48 hours, we try to cut down the fluid as much as possible, try to de-resuscitate somebody a little bit, because it is all because of the abdominal wall edema, the edema inside the bowels. So that dilates and the bowel goes into ileus. So that is what contributes to the abdominal compartment syndrome in patients with acute pancreatitis. So you decompress your stomach with the NG. If the colon is hugely dilated, you can think of decompressing the colon with some tubes, but most of the time it is not required in patients with the pancreatitis. But somebody who has gone in abdominal compartment syndrome because of some valvulars or something like that, in that case, you can think of it. And in terms of medical management, suppose this patient goes on a ventilator, then you need to sedate the patients, paralyze the patients to take care of the abdominal wall tension. And most of the time, patient prefers to we need to keep the patients in a supine position so that to to prevent the diaphragm going down and the pushing the abdominal content further down and increase the intra-abdominal pressure. So that is important.
Okay, sir.
So we proceed. So we'll go
Okay,
to
what
the
about acute abdominal compression syndrome with this positive fluid balance? Now 7 liter of fluid balance.
yes, yes.
Yes, we'll give diuretics for that or
So, if your inflammation settles, first of all, again, it depends on the how the patient remains after 48 hours. Suppose your patient keeps on requiring fluid even after 48 hours, first of all, that's not a good sign. We'll try and identify whether there is some, whether apart from this inflammation due to the pancreas, the patient is having any other cause to remain in the in the state of hyperinflammation, like whether the patient is going in a sepsis or something like that. We'll try and identify that part. Most of the time the we once the oral nutrition gets started within 24 hours we cut down the fluid, and then next 24 hours we almost stop the fluid, and then try and resuscitate the patients as much as possible. If the patient remains fluid responsive even after 48 hours, and the patients you need to give a lot of fluid, that means there's something else is there which you need to pick up and then treat that. And like if the patient might be going in a septic part after with a lot of blood translocations and all, so that you need to address that part. Or patient is going in a kind of severe necrosis which is having a persistent inflammation, so you need to address that part. Okay. Okay, so we'll proceed. So day 4, the patient becomes more tachypnic. SATs is around 90 to 93%, 6 liter O2. ABG has been given. PO2 is a little hypoxic. PCO2 is 24. Bicarb has gone down. Lactate is 6.5. The patient has developed lactic acidosis over here. So what will be your immediate next plan, and what will be protocol for the fluid management? Okay, what will be your immediate next plan? Anybody? Am I audible?
Airway protection is significantly hypoxic
Yeah, so the patient is
with the
giving quite a bit of oxygen. So you can try some HFNC kind of things, which is fine. But most of the time, these kind of patients who remains tachypnic after day 4, day 5, then that means that probably patient is heading towards intubations, and probably we need to ventilate the patient. Protocol of the fluid management, always whenever you have been asked regarding the protocol of the fluid management, please talk about we'll manage the fluid as per the dynamic assessment, and please do talk about the bedside echo. Somebody who is spontaneously breathing in this technique, please do not talk about this. We'll monitor pulse pressure variation, SPV, and all these things, because they do not work. Please do not talk about those parts. Talk about all these, we'll do a bedside echo and try and understand how is the LV VTI, and how is the LV contractility and all. We'll try and assess that part, and that is how we will give the fluid. Please do not talk about. A lot of people have talked about the PS pulse pressure variation and SPVs and all for the fluid management guideline, which doesn't work in somebody who is this tachypnic and somebody who is spontaneous breathing. So moving towards, we are just patient got intubated. We have taken the invasive lines. We started on the norepinephrine. So what do you think about the X-ray?
it shows bilateral pulmonary congestion, hilar congestion with the extensive B lines in both the lung bases.
Mhm.
So he's in fluid overload actually, probably early ARDS. So we'll use lung protective ventilation for him.
Yes, 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 yes. So what is the ventilation strategy? Yes, as you rightly said, doctor. So it's a lung protective ventilation. And just briefly talk what is a lung protective ventilation. Like we use a tidal volume around 6 ml per kg body weight. We'll use we'll maintain the tidal volume. We'll keep an eye on the plateau pressure. We'll keep an eye on the driving pressure. We'll keep an eye on the lung compliance, and then we'll use a little bit of PEEP. We'll adjust the PEEP as per the PEEP table. We'll adjust the RR as per the PCO2. So those things you just briefly tell within one line and one sentence, and then that is done. How to counsel your relatives regarding the prognosis of the patients? Again, somebody's got here again the counseling part. In all CCAs, you will be facing at least one questions where you will be judged how you what will you talk to the patients, how objectively you can counsel the patients regarding the prognosis part. Again, you need to, whenever you are doing a prognosis, you should talk about, okay, this is a severe acute pancreatitis. You should know what is the mortality of the severe acute pancreatitis. What is the mortality of somebody who is in ARDS patients? So you need to be able to talk in that objective matter. So anybody knows that, suppose if I ask you that what is the mortality of patients with the severe ARDS? Suppose this patient is in severe ARDS due to the pancreatitis. What is the mortality? Anybody? What is the mortality as per the standard literature internationally in patients with the severe ARDS?
I think around 45-50%. I think something around that.
Is your number validated by any literature, any article, or any trial or something like that?
I have read somewhere. I don't remember exactly.
Yeah. So if you see that the JAMA trial that has happened in the which talks about where the mild, moderate, severity classifications have been made, and there it has been given that what is the mortality in the somebody with the mild pancreatitis, mild ARDS, what is the mortality in the moderate ARDS, and what is the mortality in the severe ARDS? Severe ARDS means anything in the mortality is around 40%. So it's an international standard, and every day the mortality is coming down as the age increases, the mortality is coming down. We should know again, what is the mortality as per the BICEP score. Like this patient will be, what will be the BICEP score of this patient by now? Anybody? So again, BICEP score acts as a good mortality indicator. So we should say that this patient's BICEP score is this much, so the mortality, approximate mortality is this one. So we need to counsel the relatives as per that figure. So that is examiner will try and understand from your answers whether you know that the mortality figures or not. You can't say that there is like that, okay, this person might die, 60% of mortality chance or 20% of mortality chance. On which data, on what? So everybody will talk in a different, everybody will give a different number. That doesn't make any sense. So if you need to talk objectively, it's better that we know that what is the mortality figure as per the severity assessment data. So again, for all kinds of disease, like this is an acute pancreatitis, for severe ARDS, for sepsis, everybody, for somebody with a septic shock, what is the mortality? So we should be able to talk. Just 1 minute. Hello. Yes. So let's proceed. So again, so your exam has now completely diverted. So on day 2, you do a tracheostomy. Day 15, patient is having new onset fever. You send a cultures. You suspect eclampsia as a cause of fever. How do you diagnose eclampsia? So again, it's a very important question for anybody who is giving examinations.
Doctor,
Any
the question, okay, doctor, sorry for interruption. If the question clear from the relative, if this patient is survive, what I say no or yes, or I hope that.
Tell me, sorry, I didn't get a question.
Yes, yes. If relative ask me frankly, this patient is survive or no?
Sorry, I'm not able to hear whatever telling. Sorry, can you please
if the relative
is the relative?
Okay, if the relative ask me frankly, this patient is survive or no? What I say?
What do you think, doctor?
Okay, if the family ask me.
So what do you think, doctor? What you should say? There are a lot of background noise. Can you please mute it? A lot of background.
Yes. Okay, according to the severity of this patient, according to BICEPs and according to the RDS, this patient mortality is very high. If the family ask me, this patient is survive or no, what I say?
So what do you do normally in your routine practice? What do you say? What do you think you should say?
Really, here in the Middle East, we'll say yes. I hope that we survive. We will do the best for the patient.
So the way you should say, first of all, you need to talk more empathically. So that is one of the most important part over here. And secondly, clearly, it is not a futility of care in acute pancreatitis, that you know. So unless somebody is in a futility of care, you should try to give them a figure. Okay, in this kind of patients, the mortality is around 40%. Okay, this because this patient has severe ARDS as well, the mortality is around 40%. So the probability of is like that. But again, this is not the end. We're doing everything to make him better, and we'll take care of him. And it's not, as it is not a futility of care, you should not say that the patient will die. So it should not say so.
Okay.
So that means that if somebody's mortality percent is around 40%, then the chance of survival is around 60%. So that makes it that. So how you try that, it's a different. You say that we try whatever possible to make it survive.
Okay, thank you.
Sure. So we'll proceed. So again, the entire case vignette has now changed. So it has gone to a CLABSI. Everybody should know what is the definition of CLABSI. Should know how to diagnose CLABSI or central and associated bloodstream infection. Again, to my utter surprise, only one person could able to give me the kind of entire definition of the diagnostic criteria of CLABSI. Rest everybody has some amount of confusions with there. So three things are important. First of all, there has to be some clinical sign of infections like fever, rigor, some sign of infection, or some sign of sepsis has to be there. Secondly, there should not be an alternative source of bloodstream infection. And thirdly, which is the most important part, there will be two paired blood sample will be there, one from the peripheral vein, one from the central line. The blood, both the samples should grow the congruent organism, and it has to be like either the sample taken from the catheter or central line, the colony count will be at least threefold higher number, or there will be a differential time of positivity of at least 2 hours between the growth in the central line and the growth in the peripheral line. So all these three things has to be there. So like I've asked very specifically what is differential time and positivity is very important because that is how we diagnose central CLABSI. And always talk about this clinical definition. There is another surveillance definition of CLABSI as well. Do not talk about surveillance definition. Talk about this clinical definition part on. Again, questions changed now. Hello? Yes? Anybody? Okay. Coming to the weaning part, how to wean the patients. So what parameter will you check before weaning the patients? Again, very easy, very standard question. They are you will be asked, but again, your answer should be very organized. So next three questions: one for the weaning part, one for the deconvolution of the part, and one for the critical illness part. Weaning part: how do I identify the patient is ready to wean? So why? Whether you can go by ABCDF criteria, or is a kind of more practical criteria is like somebody. Most important, the why somebody gone on a ventilator, that part needs to be resolved. So here the patient developed pancreatitis and then ARDS. So that is why the patient went on a ventilator. So his ARDS needs to be resolved, his pancreatitis needs to be resolved. That is how the patients comes out of when you should think about weaning the patients. Before that, there's no point of thinking about weaning the patient from the ventilator. The patient's pH ratio should be adequate. pH should be more than 7.25. Like it's not applicable over here, but pH ratio is more than 150. Should be hemodynamically stable, and should be otherwise stable, and patient should be otherwise conscious and arousable. Or you can go by ABCDF criteria. So, but we need to talk a little bit of more organized way. Regarding the deconvolution part, 4 things are important for the deconvolution. We need a conscious patient, who is conscious and oriented patient. Second, somebody who has a patent upper airway. Suppose somebody is very conscious, but there is a laryngeal tumor is there. We cannot think of decannulation, or somebody patient has developed some vocal cord edema. You cannot think of decannulation. So should have patent upper airway. Thirdly, the patient should have a good cough. So that means the patient should be able to clear secretions. So what we do, we just diffuse the cough and then see that the patient is able to cough or not, and take care of the patient's own secretions or not. And patient is out of the ventilator for quite a period of time. There are 4 criteria. All 4 criteria needs to be fulfilled before decannulation. Sometimes, most of the time, we can decannulate safely on the basis of a clinical assessment only. Sometimes, what I can do, we can just block the tracheostomy with a speaking valve, see that whether the patient is able to talk or not, patient is able to clear the secretions or not. So you get a lot of information with the blocking the tube with a speaking valve. So tolerating speaking valve more than 4 hours, 5 hours can safely decannulate. ICU required weakness, again, it's a very standard question, should know what the risk factors are. ICU required weakness, I think we had a already separate class on this, so I'm not going into details, but please, everybody please read this topic. We do not read this topic much, that is everybody we do not give, and we cannot answer in the exam, but it's very important chapter from the exam point of view and from the clinical point of view. Please everybody read about ICU required weakness. So that's all on the CCA's part. So any questions, or we'll go to the case-based scenario? Okay, so we'll go to the case-based scenario. Case-based scenarios, again, all case-based scenario can be on your X-ray, it can be in a radiograph, in a CT scan, MRI, it can be a flow volume loop, it can be on the ventilator graphics, can be ECG, can be ABG, and all these things that they come as a case-based scenario, or some clinical case vignette with a short one-line questions. Like somebody come with a road traffic accident. What do we see over here? Again, I think most of you could identify these conditions and could answer standard easy things, to be very frank. But again, things that you should be able to pick up. First of all, there are multiple rib fracture. You should count. Third, fourth, fifth, sixth rib fractures are there at least. What I can see. There is a traumatic hemothorax. You should talk about it. There's an ICD in situ which has been probably put because of this traumatic hemothorax. How do you understand it's a traumatic hemothorax or not? Because the clue is there, the patient is hemodynamically unstable. We cannot see any pneumo over here, so probably it's a traumatic hemothorax only. And patient is an ICD in situ. Should say probably it is because of this traumatic hemothorax with a multiple rib fracture. What's the plan of management? Again, somebody with a traumatic hemothorax or somebody with a trauma in the chest. Always talk about, apart from this ICD part, always talk about ICD and the resuscitation part, should talk about the pain management. How will you provide analgesia to this patient with, again, multimodal form, and preferably thoracic epidural analgesia or paravertebral block. Question 2, again, everybody is able to understand. What is this? If I ask you, yes, so your answer ends with subarachnoid hemorrhage. Please do not do that. It is subarachnoid hemorrhage, but again, within subarachnoid hemorrhage, again, we have given a clue over here. There are a lot of brain edema we can see. There is absence of salsa and gyrase there. The cisterns are compressed, so there is an evidence of raised intracranial pressure. We should talk about the subarachnoid hemorrhage. It's a diffuse with cerebral edema. And we should try and assess the severity of the subarachnoid hemorrhage. How do we do the severity assessment in subarachnoid hemorrhage?
Fisher grading. OCT by Fisher grading. I mean, modified Fisher grading.
Yes. So what we should know about the 3 grading systems. One is Hunt and Hayes, which is on the basis of the clinical scoring system. The WFNS scoring system, again, on the basis of the your clinical scoring system, and one radiological scoring system, which is the FISUS grading scale. Here, over here, it's diffuse. So if I need to tell you that What is the grading system over here? So there is a component of IVH over here, and it's a diffuse blood over here. So it's a FISR 4. So we should be able to tell what grade it is. It is better you tell the grading of the CT scan as well. But at least you should say that there's a abdominal hemorrhage with diffuse cerebral edema or evidence of raised intracranial pressure. Please do not talk about only cerebral hemorrhage and then stop because your marks are half now. Again, we have been given it a, so again, extract the same patient and we have been provided with X-ray over here. What is this? Describe the X-ray. Again, please do not talk about X-ray, PA, AP, and all these things. Nobody's interested to know those things. What is this? X-ray? It's a
Right-sided upper lobe
Iris.
collapse.
so it's an endobronchial intubation with a right side upper lip collapse. So to complete it, just tell only right side upper lip collapse. Then next question is where is the tube? The tube in the right bronchus, and that is the cause of right. So you have to complete. You need to identify entirely. Take your time for maybe 10 seconds, 20 seconds, and then give answers. Do not jump to give answers, probably. Just see a little bit more carefully. Maybe we're giving right answers, but just try and find that there's something additional things are there which you can. Because as I'm telling you repeatedly, examiner always sits with a tablet and with the answers inside it. You'll just check tick whether he has talked about right endobronchial intubation and he has picked up the right upper lobe collapse. It's done. You talk about only one, your marks is half. What is your plan? Take out the tube and put it in the inside the trachea, and then you do a good suctioning and then treat the collapse part. So that is how we do a treatment. What is this?
Pulmonary embolism.
Yes, pulmonary embolism. Diagnosis:
Bilateral pulmonary.
acute, bilateral, segmental. What is this? It is there even the right bilateral main pulmonary trunks as well. So both right and left pulmonary trunks that is there. Main pulmonary trunk is there involved. Segmental layers are there. So it's a bilateral pulmonary embolisms involving both right and left pulmonary trunk and its branches, segments and subsegments. So that is again how we need to complete the sentence with oligemic lung field. So that is how we complete the entire sentence. How to decide the plan of treatment in pulmonary embolism?
It depends
Based on
on
the hypoxia, hemodynamic stability.
Hemodynamic stability.
So what do? We do the severity assessment in the pulmonary embolism. How do we do a severity assessment? We classify the severity as per the low risk, intermediate risk, and high risk. Anybody with a high risk means somebody with the evidence of hemodynamic instability, or somebody whose SPC is more than one. There is an evidence of RV dysfunction. That means probably they might need to thrombolize. Otherwise, all intermediate or low risk, probably you should start therapeutic anticoagulations, and you should look for the source of the clot. Maybe you can consider doing a DV risk assessment and something like that. But again, the treatment is either thrombolysis or anticoagulation, or a mechanical thrombectomy.
So that intermediate risk, high versus low intermediate risk, how to differentiate?
So for the thrombolysis, somebody is hemodynamically unstable, you thrombolize. It's very simple. It's better to keep it simple as much as possible. Hemodynamic instability, thrombolize, because you go by the ACC/HA criteria guideline. They also said the hemodynamic instability, you thrombolize. Somebody hemodynamically stable, doesn't have any lot of IRV strain or RV dysfunctions, probably then you can start therapeutic anticoagulation. It doesn't depend on how hypoxic the patient is. It doesn't depend on what is the clot burden. So most of the time it depends on the clinical criteria.
So you can consider later on according situation.
But whenever you talk in the exams, please talk whatever is written in the guideline. So either you talk about the ACC guideline or you quote the ACC/HA guideline. Okay, proceed.
yes.
What is the diagnosis over here? Young lady with a fever, with an episode of seizure, some weakness.
Most probably herpes.
There is a right temporal
Yes,
hyperdensity seen. Probably viral encephalitis.
Very
Yeah,
good.
maybe for the herpes simplex.
Yes, very good. So again, nobody could talk about the probability. Nobody has talked about this herpes simplex, and it's an herpes simplex encephalitis. Why is herpes simplex? You can talk. You can tell it is a mostly it's a
That's
viral.
because it's lovely place is temporal region.
Herpes simplex characteristically involves the temporal part, so that is why probably uh, mostly it is a herpes simplex encephalitis or meningitis only. How to diagnose? It's done. How will you manage? You manage with an acyclovir, and first you do an LP, do a test for the viral etiology, and then start antivirals.
So what is this, Doctor? Sorry, I can't hear this. In MRI. So I can't hear what is this in MRI. This
Yeah,
mass.
this is MRI. This is T2 MRI. Again, you should know what is T1, what is T2, what is what is the diffusion imaging, what is the EDC imaging. Those things you should know in the MRI. These are basic MRI things are there. So this is a T2 image.
I mean, this is in temporal. This is like
This is a temporal. So it's a T2 image, T2 MRI with a hyperintensities involving the temporal lobe. With the background of this specific history of fever and the seizure, most probably it's a viral encephalitis or viral meningitis. And as it doesn't involve the temporal lobe, most probably etiology is probably herpes simplex encephalitis. So that is how you complete your answer.
oh,
Okay.
okay.
What is this? Again, flow volume loop. What is happening
There's
over
leak.
here?
There's
Leak.
Leak.
Although again, do not jump into a leak. Just try and describe the things as much as possible. Like the expiration leak has not reached the baseline, so most probably there is a leak. What action would change the ventilator setting? What mode of ventilation this is? There was a respiratory problem over here. What mode? Again, everyone.
It is a volume controlled mode of ventilation.
Volume control. This.
How do you understand it's a volume control ventilation?
And there is square
There is
wave pattern in the flow volume loop seen.
So it's a
Flow time graph.
volume control ventilation
flow.
means they are flow limited ventilation. So it's flow limited ventilation. So that is it's a volume control ventilation. What is the respiratory problem over here?
There is increase in flow, and as well as the expiratory limb is smaller, indicating bronchospasm. So the flow is more also, and there is bronchospasm also seen.
See the entire picture again. Be very frank. So why I have kept the right side? That means you have not seen the right side of the. You are only concentrating on the flow part. What is the peak
There is
pressure?
increase in peak pressure,
What is the plateau pressure?
plateau pressure also.
So the plateau pressure. What is the lung compliance? Please calculate the lung compliance. What is the lung compliance over here? Anybody can calculate the lung compliance? What is the formula of lung compliance?
The tidal volume divided, I think, the plateau.
P back minus P plateau.
Tidal
What is the lung
according
compliance?
static plateau pressure minus
It's
P.
around 54.
Plateau pressure minus P6. Like
What is the tidal volume over here?
270.
400 over
by 27.
plateau.
By 27, this mean 10.
20.
Anybody else take
270 by 27. This is 10.
Yes, tell me.
Yes. This is low compliance. Low compliance.
How much is the compliance? 270 divided by 32 minus 5.
Minus 5. Minus 27.
270
Almost
divided
9.7.
270 divided by 27. That means around 10 is the compliance. So that means it's a
Yes.
high compliance, low compliance, medium compliance. What is this?
Sorry to interrupt, sir. Sir,
Yes.
it's 3:45. It's there more slides left?
No, I'll finish in next. I'll try to finish in next 5 minutes.
Okay, sir. So we have more 5 minutes. Dr. Ganadhar sir have already joined us.
Oh, no problem. So this is a low The compliance is low, so this is most likely problem. What is the respiratory problem? The compliance is low, so probably patient is having rabies. What will be your interventions? You will increase P, you will increase set the tidal volume as per the A, and you will give a low tidal volume setting. So that is the thing. Next we'll go. What is the mode of ventilator?
It's again volume control mode of ventilation.
Oh, it's not a volume control. Again, please, everybody should be very, very familiar with the mode of ventilation, because examiners will expect you to know that of which mode of ventilation. It's not flow limited ventilation. It's what? It's a pressure support ventilations. What is the problem? So patient is having
Ineffective trigger.
Increase your trigger sensitivity. And otherwise will kill me. What is a problem over here? So somebody has CPR, CO2 suddenly increased. That
With
means
retain of internal circulation.
okay. What is this? The AKI put
Hyperkalemia, hyperacute T waves.
Almost sinus kind of pattern. So tall T wave. Patient is a junctional rhythm. Tall T wave with a junctional rhythm with a background metabolic acidosis. Probably patient is hyperkalemic. How will you manage? You can try the diuretics. Not happens. There's already written patient is oliguric. Maybe straight away better to go on a dialysis part, and you give a standard anti-hyperkalemic things. 56-year male, sudden classic chest pain. ECG is like this. So what is this? There's 2-3
Inferior wall MI.
The inferior MI with
only thing in
the RVMI.
And this was right with RV infarction.
Yeah. So why there is an RV infection? Anybody infra lead? If lead 2 is more than lead 3 is more than lead 2, we suspect RV infections, and there is some ST elevation in V1 as well.
But this has also inferior MI.
Yeah, inferior MI is mostly associated with the right ventricular infection. It's a right RV infection.
So both.
Yes, this is RV, and this is. I'm not going to. Did I ask these things to anybody? I do not.
Tumor lysis syndrome.
Lysis syndrome. I do not know whether I have asked. I don't think I have asked this question also to anybody. Question on CRRT. Did I? Again, I do not know whether I have asked these things to anybody or not. Yes, this question I have asked. 16-year-old boy came with a history of chronic cough, fever, 2 days, ran an ECG, and he has been on the ECG. What do you feel?
It's probably wrong lead placements or dextrocardia.
Very good. So you just check that whether the systems have put up proper leads or not. If the leads are fine, then it's a dextrocardia. Then what is the most likely diagnosis over here? What do you think somebody who has a dextrocardia with a history of chronic cough in a young boy? What do you suspect?
Pericarditis.
No.
Cystic fibrosis, cartilage syndrome.
Cartilage syndrome. Very good. Very good.
What is this?
So mostly young boy, the bronchus disease with a dextrocardia, should think of cartilage.
I think the history of dextrocardia and chronic cough and sinusitis, maybe bronchitis, something wrong like that name.
Okay, so that is all. So mine is done, Fatmaji. So anybody wants to ask any questions over here? Otherwise, I'll conclude and Dr. Gunadhar will come in.
Volume control ventilation that you told, it was pressure support ventilation. It's only on basis of the waveform that it was not as sharp as it should be. I can't hear you, sir. Your voice is off.
So, sorry, what did you say? What did you ask? Actually, you could not answer the last one. You could not identify whether it's a volume control or pressure. Volume control, the flow will always be limited. Volume control ventilation means the flow limited ventilation. So, any point of time here, what we have seen in the graph. So, initial the flow will be high, and then the flow goes down, and then the patient cycles, and then it develops the ventilator cycles to the expiration. So, this is typical of pressure support ventilation. So volume control ventilation flow will be limited, at one part, and the flow will remain constant throughout the inspiration, and then patient will break into expiration. So that is, always look at the flow time curve to identify whether the patient is a volume control mode or pressure control.
No, that graph was pressure control or pressure support?
So there is a pressure control mode.
Sir, there are
And
some
how do you differentiate
ventilators.
between-
In volume control, we can also give decelerating flow.
Please, you can argue about that part, true. But again, you look at the you look at the pressure time curve over there. All volume control ventilation, the pressures are not static. The pressure depends on the lung compliance.
Yeah.
Whereas pressure control ventilation, the pressure remains static. So because that is a control parameter. So it's a pressure limited ventilation. So in that patient, the pressure went up and then it remained limited. So it remained constant. Whatever is the mode of the volume control, whether it is a decelerating flow pattern or it is a constant flow pattern, the pressures will not remain constant in volume control ventilation. What is a volume control ventilation? It's a volume limited ventilation. It's a flow limited ventilation. So your flow is limited, it's a volume control ventilation. Your pressure is limited, it's a pressure control ventilation. Keep it as simple as that. Do not go into
and
any
pressure support and pressure control, other than the shape of the curves, which can be very smooth in pressure control, but in pressure support, it will be not very sharp and smooth. As that's the only way we can differentiate between them.
Well, if required, I'll tell them to. Ventilator graphics is very important topic. Everybody should know about that thing. We can have a separate class on that, and everybody should be very conversant about the ventilator graphics because people will expect, because ventilator is bread and butter of all the intensivists. So examiner will expect you to understand thoroughly about the ventilator graphics part. So please, everybody read about the ventilator graphics before going to the exam. Okay. So
Okay,
Ian,
thank you.
Thank you, Suvadeep, sir.
thank you. Somebody has
So we
given
are,
a goal.
okay, so we are done with the debriefing session, right?
Bye. Yes, I'm done with my debriefing session.
Okay, sir.